Draping for the endoral approach is similar to the standard TMJ draping procedure with a few exceptions. Benzoin is applied to the preauricular areas to provide a good adherent surface for the tape. We prefer paper tape as it will absorb the prepping solution and provide an antibacterial barrier. In addition to the normal facial prep, the endoral approach also requires the prepping of the external auditory canal with a cotton applicator and prepping solution. Benzoin is again applied to the maxillary lip, preauricular areas, and cheeks to aid in the placement of the sterile V-drape superiorly and inferiorly. The excess V-drape is placed in the mouth to provide a sterile barrier through which the surgical assistant can manipulate the mandible. Ear drapes are then applied to isolate the endoral and preauricular areas. Here you can see the equipment laid out in a very simple manner. It is useful to keep your instrument tray as simple as possible with extraneous instruments being removed. This is for a lysis and lavage, the basic instrument tray. This is the inflow, little sheath, the various trocars, the arthroscope, a clamp, and a external auditory canal pack to be placed. Marcaine 1 cc with a 20 gauge needle. Only 1 cc is used in the syringe, so excess won't accidentally be injected, causing a postoperative nerve lag. The ice-temperinized lactated ringer solution. Outflow portal, 18 gauge short bevel needle with 2K50s. The extension tubing being taped to the basin so as to keep the tip of the outflow visible out of the puddle of outflow fluid at all times. The camera is being demonstrated with the seat clamp and the light source. The instruments in their sterilization case being demonstrated here with various files, knives, the basket forceps for biopsy, alligator clamps, and scissors. With the mandible distracted downward and forward, the surgeon places his finger over the lateral pole of the condyle and palpates for the posterior pouch. The Marcaine is injected in the superior joint compartment with the needle beveled at an angle of 45 degrees in all dimensions, angling towards the posterior slope of the eminence. The needle is stabilized and left in place, and the ice-temperinized lactated ringer solution is utilized to then create a distension of the capsule while the outflow is established in the anterior superior synovial pouch. This is accomplished with the mandible distracted downward and posteriorly now, and then the 18 gauge short bevel needle is introduced into the anterior superior synovial pouch for through and through outflow. Here we can see the through and through flow going up through the K50, and the ice-temperinized lactated ringer solution is then carried on out through the outflow cannulas and extension tubing into the basin. Application after removal of the initial needle from the wound, application of the heparinized lactated ringer solution is given to the outflow portal. This is then temporarily used as an inflow distension portal. The capsule is then able to be continually distended while the surgeon punctures through into the joint compartment, thereby minimizing the amount of soft tissue damage along the surface of the eminence and fossa. Two distinct puncture impressions are made with the fascia and capsule, and with removal of the trocar, usually a mild amount of pressure on the outflow needle will then allow for through-and-through lavage and confirmation that both instruments are in the same joint compartment. Clamp is then applied to the outflows and the syringe removed. This prevents air from being introduced into the joint. And the inflow portal is then attached to the cannula, and flushing of the bubbles from the sheath is accomplished while the arthroscope is introduced. This is snapped into place, and finger rest stabilization is noted here. Removal of the clamp then allows for the continuous lavage and outflow to be observed by the surgical scrub nurse, and with positioning of the camera cord to the inferior allows for 12 o'clock positioning of the image. First thing visualized is usually the medial capsule, and then shooting up the medial trough. The shadow of the pterygoid muscle coming through the capsule is noted. The synovial markings with vascularity are noted on non-articulating surfaces. Then looking upward toward the glenoid fossa for any pathology is accomplished. The attachment of the bilaminar zone to the cartilaginous portion of the external auditory canal is noted, and then movement of the condyle, disc, and bilaminar zone is demonstrated. Now traveling up along the lateral trough, we can see a small fibrillations of the surface of the disc and some areas where there are adhesive capsulitis, adhesive restrictions of the movement at the 11 o'clock position. With the arthroscope pressing through these areas, you can have some small amount of lysis occur. You can see these areas demonstrated. Also demonstrated is a small iatrogenic scuff mark. Scuff marks iatrogenically placed are characteristic in that they are linear in pattern as opposed to the fibrillated and irregular pattern of an adhesion that has been broken free or lysed. A small amount of disc mobility has been accomplished just from this. However, further lysis will be necessary to allow for complete mobility. The placement of the trocar into the sheath is then accomplished, and sweeps of the articular eminence as well as articular tubercle laterally and anteriorly are accomplished. Stretching of the capsule is desirable as well in the lateral dimension. Re-entrance into the joint with this particular case shows the medial capsule, the articular lateral surfaces, and with smooth gliding of the joint being accomplished. Removal of the instrumentation is then shown here with pressure applied for hemostasis and placement of the external Band-Aid dressing. Also of importance is the direct visualization of the external auditory canal and tympanic membrane with an otoscope postoperatively. This helps to ensure that all of the packing has been removed and that no damage from extravasation has occurred. This is obviously important in correlation to the preoperative examination, and this must be accomplished in every patient. The appliance is then placed to the maxilla. The orthotic appliance's purpose is to stabilize the disc and to position the condyle-disc fossa relationship properly. Postoperatively, we have found that physical therapy and physical therapists play a crucial role in the prognosis for these patients. Most physical therapists do require postgraduate training in specific techniques to help treat the temporomandibular joint properly. Manual distraction with glide manipulation provided immediately postoperatively and several times weekly to the patient do help to prevent reoccurrence of superior joint compartment adhesions during the healing phases. We feel that this is especially important during the first 21 to 30 days postoperatively. While long-term follow-up on TMJ arthroscopy is not yet available, we have found that this technique in our hands have proved beneficial to our patients and has eliminated the need for open joint arthroplasty for the majority of cases involving adhesions and closed lock disorders. It is our feeling that long-term follow-up will substantiate these early results and that TMJ arthroscopy will become one more option available to the oral surgeon for the treatment of the TMJ disorder.